Good afternoon, everybody. Thanks for carving out time to be with us. I'm Pete Hansel, Isla's CEO and co-founder, so I'm very excited to be your host today. First time for me hosting a webinar, so don't judge too harshly. I'm joined today by two incredible panelists, Professor Giuseppe Garcea, who's consultant HPB surgeon and Deputy Medical Director for Planned Care at the University Hospitals of Leicester, and Dr. Flora McErlane, who's co-clinical lead for Paediatric Rheumatology with GIRFT, and also consultant Paediatric Rheumatologist at the Great North Children's Hospital in Newcastle. So Flora, Giuseppe, thanks so much for taking time. You're both practicing clinicians, so really interesting to hear sort of from the front lines what this topic looks like in terms of sort of delivery and how we actually make digital pathways a reality within the system. So before we get started, just a quick bit of housekeeping. The session is being recorded, so we'll share this video this afternoon on Digital Health website, so you'll all be able to access it there. We also want to make this very much a kind of audience participation webinar, so very much encourage your engagement. We'll do a quick poll to get things started, just to understand sort of where people are coming from with this. And then please use the chat kind of throughout the webinar really as things come up, and then we'll have some dedicated time at the end to hear from Flora and Giuseppe on those answers. So I'll just get us started. So to sort of set the scene a little, I suppose, we all know the reality of the pressures on the NHS. I think it's fair to say there's a monumental effort being put into improving the service, and actually I'm very optimistic and hopeful that we're beginning to see some of those improvements really starting to bear fruit in terms of the nationally reported metrics. I think the thing that is always true is that behind the scenes and behind kind of the press commentary on the NHS, there's an enormous group of very, very passionate, very driven people who put in a massive amount of work to move this complex system forwards. So I'm sure many people on the call are very much part of that. We're here today to talk about digital pathways, which is an area which I believe holds absolutely huge potential for the system. The principle is quite straightforward. So really what we're talking about is to begin to look at the patient's movement through the health system, right from primary care through to recovery and self-management and sort of surveillance out the other end, and to think about that kind of every step along the pathway, how we can use data and automation to prevent the delays which we see today. And if we can get that right, then we have the opportunity to begin to sort of standardize these pathways, these best practice, highly automated, highly efficient pathways at regional and potentially at national levels, which helps us then to deliver this kind of optimized experience wherever you are in the country, and begins to address some of the unwarranted variation which we see currently across the system. So as I said, Giuseppe and Flora are kind of right at the heart of developing this within their own services and specialisms. So I think there's nobody better to hear from today to kind of help understand the on-the-ground reality of how we can make this happen. So channeling my Stephen Bartlett, without further ado, let's dive in. Neil, if you would just get us started with the audience poll, I think it'd be interesting to kind of get a sense of why people are tuning in today. Thank you. So we'll just take 30 seconds to give people a chance. This is single choice, just to run it through. So if we could wave a magic wand and reclaim 20% of clinical time through automation, where should we be using that time? There's obviously a huge focus on the elective waiting backlog. There's often we hear that clinical time is being compressed, and that it would be beneficial to be spending more time with more complex high acuity patients. There's a real kind of genuine, I think, risk of overstretched clinical teams and staff burnout, and with a backdrop of increasing demand across actually most clinical services across the NHS. So interesting just to hear kind of where the audience thinks that time would be best deployed. Interesting, so votes coming in. Hopefully everyone can see this in real time in the chat. So yeah, a bit of a congregation around expanding services to meet demand. Yeah, very interesting. I suppose in some ways the 1 and 4 are very interrelated there, aren't they? So if we can be freeing up capacity to increase service capacity, then that's going to tackle the backlog for us. Okay, we'll let that tick along in the background and come in, and then Giuseppe, Flora, if you could kind of try to weave some of this, I suppose, into your answers as you move through, that would be interesting and helpful. So let's get straight into it. I've kind of introduced you, but please just, I think it's always very interesting when we hear from panelists to kind of get a sense of your roles, where you work, your priorities, how it looks day to day. So if you could kind of weave that into the first question. Giuseppe, I'll come to you first, and then Flora, same question for you. So after you've kind of introduced yourself, it'd be really great to hear what your sort of frontline experience of pathways is, and I suppose particularly to dive into the title of the webinar, which is Scaling Excellence Through Digital Pathway Standardization. So looking beyond the tech, but incorporating the tech as you wish to, what's important about standardized digital pathways, and can they actually help us to improve performance across the service? Giuseppe.
Okay, thank you. Hopefully you can all hear me all right. So yeah, I always get really worried in my role in plan care, because I deal with lots of different specialties, when you have significant variation within a specialty, for a couple of reasons, actually. I think at the clinician front end, my worry is that you really have got to question how well the dynamics of the team are working if there's significant variation. Medicine is complex, there's no doubt about that, and there are nuances in care, but evidence-based medicine and what is the correct treatment, or what is the right pathway and the right investigations, they should be pretty much standardized for the lesser complex stuff. If you don't have that, it always reminds me of the shopping queues you get in supermarkets, you know, when you've got one line that's going a lot longer than others. Yeah, because you've got variations in treatment, you've got variations in investigations, and you've got variations in patient outcome. So from the clinician perspective, it concerns me. And I think digital can go a long way to standardizing the baseline and then improving on it. From a patient end, I think the issues are you can't move patients around. So if you're assigned to consultant A, and consultant A likes to do 5 different tests before they see someone in clinic, you're going to be waiting longer for your treatment, and you can't pull patients particularly well. They also don't know what they're getting. It becomes very difficult to try and do preoperative informational optimization, because the exact specifics of what investigation the patient gets will vary between clinicians, and you've got this variable weight between patients. From an operational perspective, modeling capacity is really difficult because you haven't got a stable baseline. There's very little you can do in terms of flow, because everybody's doing something different. It's a bit messy. You can't outsource is probably the wrong word, but you cannot delegate parts of an investigation pathway, for example, to an intermediate tier workforce, because everyone's doing a slightly different thing, and no one's got a proper baseline. It's harder to identify bottlenecks and where true gaps in capacity and demand exist. So for all of that reasons, you end up with a reactive, messy service where it becomes really difficult to understand what the ideal pathway is, and therefore it becomes very difficult to then decide how you optimize it. And it links into what someone's put, focusing on complex high acuity patients. So, you know, I work in a teaching hospital. There's a lot of very complex patients that come through. A lot of it is still quite simple, because that's just the nature of what we do. And if you are losing a lot of noise and resource in moving along the straightforward patients, you are affecting all 3 things in those pole, or all 4 things in that pole. You're creating long waiting times. You're not helping to reduce the elective waiting list backlog, and you are very definitely allowing less clinician time to focus on the higher acuity complex patients that do need that extra special bit of time to get it right.
Thank you, Giuseppe. Flora,
come in there.
over to you.
Yeah. Hopefully you can hear me okay. So yeah, I'm a paediatric rheumatologist by background, and I'm also the quality lead across Newcastle hospitals for children's and for women's services. So my ambition always has been very simply to try to ensure that the right child, in my case, gets the right care at the right time. That's all of our ambitions as clinicians, of course, isn't it? And that was part of the reason I got involved with the Getting It Right First Time programme, or the GIRFT programme, because I think at the moment, for various wide-ranging kind of between patient and between provider variations and pressures, it is very difficult to get it right first time a lot of the time. I think most clinicians now work in services that are under pressure. I'm really interested in the poll, actually. All of those things are massively important, aren't they? But coming back to right care, right patient, right time, I also work in quite a specialized area. And I think that, you know, patients travel a very long way often to come and see me. And sometimes I see patients that perhaps didn't need to travel such a long way to come and see me because they didn't need me. So there is something that's really important about getting our pathways correct so that the right clinical team can focus on the right child, instead of, as you just beautifully described, this kind of noise of people around the place that don't necessarily need to be in that spot. So you probably all know very well the Getting It Right First Time programme, or GIRFT, which is a national NHS England programme, carefully designed to improve treatment and care through sort of clinically led reviews using kind of data and much more qualitative feedback from clinical teams to examine how things are being done at the moment and what we might do differently to do it better. And one of the things that GIRFT repeatedly demonstrates across, you know, every different specialty is that we can reduce variation across the NHS, and that reducing that variation does improve care and outcomes, does deliver efficiencies, does reduce waste. And a lot of that is just the sharing of best practice between trusts. And we feel very strongly that standardising clinical pathways is absolutely central to reducing this variation. So in my world, an example of when this has worked would be actually in adult rheumatology. So in adult rheumatology, they've been involved in GIRFT for longer than we have in paediatrics. And as part of their GIRFT review, they identified real worries about variation in time from, you know, initial presentation to getting that medicine that that patient with arthritis needs to get better. So they built a new inflammatory arthritis pathway. The pathway carefully had time limits on it, so it recommended things happening with certain amounts of time, and was adopted across the whole of England. The National Early Inflammatory Arthritis Audit collects data to evidence this pathway, and it is very clear from their recent data that introducing this pathway to standardised care has improved the proportion of adults with rheumatoid arthritis starting the medicine they need within 6 weeks of referral. So that I think is quite a kind of clear piece of information about the impact that we can have if we get these pathways right. It also, I think, impacts on us as clinicians, doesn't it? Because it gives us that comfortable feeling that what we're doing fits with what other people are doing around the country. So, you know, loads of advantages.
Yeah. Thank you. I think that's a brilliant example, and that there are pockets of like really strong evidence for what can happen if we can clinically align behind. I say clinically align. Royal we. I'm not a clinician, but if clinicians can align behind standardized best practice, there's such a huge evidence base for that now. I often think of it as a little bit like a sort of franchise. I've used this analogy before and it didn't land last time, so I'll try it with a live audience and see if it's any better. But I often think of the NHS a little bit like a franchise, but without. It's like running a franchise without kind of standardizing around things like ingredients. So it's like going to a Pret, but every Pret is a different set of ingredients, and so the outcome, the end product that you're going to get is you know, by definition very different. And so I think of sort of standardized clinical pathways, digitally enabled clinical pathways, as one of those sort of consistent threads that wherever you go, you should be getting the same clinically approved standard of care, and we should be able to automate as much of that as possible, as well as kind of laying the foundation for then iterating on that really quickly. So when, you know, we're in a world now where there's fantastic research coming out, fantastic new models, computer vision models, AI models that allow us to begin to kind of dive deeper and draw deeper insight from data than we ever have been able to. And the rate of development of that's just going to increase. And so if we have a framework into which we can plug those models and launch them across the country, I think that's potentially a real kind of game changer for the future of sort of the way we deliver services. So thank you both. We'll go now on to, I suppose, a related question, but just thinking about it from the sort of human end. We've seen that standardized digital pathways, and as you've just spoken through, sort of digital pathways there can really help with convenience of patients. And Flora, you mentioned patients traveling a long way to see you. The other aspect, I suppose, of this is clinical safety and sort of addressing the unwarranted variation that you just started to touch on there. So it'd be great just to hear your thoughts, coming back to perhaps to you, Flora, with this, and then back to Giuseppe afterwards. Can you just kind of walk us through how standardizing digital touchpoints along a care pathway can help to sort of ensure no patients get left behind or drop through the cracks?
Yes, thank you. So clearly, patient safety is one of the central themes running through improving quality of care, and the NHS patient safety strategy absolutely articulates the need to improve patient safety with, you know, very predictable associated benefits for both patients and, of course, for reduction of costs across the healthcare system. In particular, I went and I looked at the other day, the patient safety strategy comments that if we get this right, we could save almost 1,000 extra lives and potentially £100 million in care costs each year. So this really matters. But to improve patient safety, back to the right care, right child, right place, we need timely interventions that improve both the effectiveness and the efficiency of patient encounters. Digital technologies are key enablers of this aim, and digital technologies are recognised not just across our country but worldwide as an important enabler of safer clinical care and feature clearly in the WHO Patient Safety Action Plan. So there's no question that digital technologies are important in the world of improving safety. I guess what's challenging for us is how to engage with them in our already busy clinical world. So certainly at GIRFT level, the potential of digital pathways has been clearly recognised, and there's a digital accelerator programme that's in place across lots of areas of the country, working directly with clinicians to build and to implement standardised but also automated best practice pathways. And the idea is that this digital enablement is probably easier for clinicians to use, and more definitely collects data at each step of the way, so we can clearly demonstrate changes to patient flow, changes to variation in care, and it allows us to kind of move forwards and modernize faster, if you like. Kind of pathways that we're thinking of developing across GIRFT are pathways that work well, helping patients to move between different services, between different parts of the healthcare system. They can include questionnaires for clinicians to make it quicker and easier for them to make decisions in clinic. They can importantly include questionnaires for patients so that we have more information with us in the clinic room when we see that patient to enable shared decision making. And of course, they can include prompts and reminders. So in that busyness of being in clinic, we don't kind of forget really key steps, you know, allowing people to drop through the cracks, as it were. So going back to the adult new inflammatory arthritis pathway, at this stage, we're trying to build a similar pathway for children. So a new inflammatory arthritis pathway, we know that there are significant delays getting children into the care they need and getting those medicines, perhaps in some ways more so than in adults, because people don't tend to think of children as having arthritis. So we are now living in a different world several years on, and we're just pondering how we go about building a digital pathway. Because we feel so strongly that this will add these sort of additional layers of checking to improve patient safety, I guess.
Fantastic, thank you. It's great answer. Giuseppe, if I can come to you with the same question. So I'm sure you do remember, just as a refresher. So how can the kind of standardized digital touchpoints along the pathway, particularly I suppose in your services where you're actually going quite broad at UHL in terms of the approach to this across multiple specialties, how can that process help us to to avoid patients kind of falling through the gaps?
So yeah, because I get this in various different scenarios. I think the actual sort of, I think you mentioned about convenience as well, didn't you? Did I get that right? Because I had an whole answer based on convenience. Yes. So because I've heard this before in meetings I've had with specialties about something being convenient as a nice to have, which it blows my mind. I challenge anyone to try and get hold of my secretary right now and navigate our UHL switchboard and get put through to Professor Garcea's secretary. It'll probably take about 10, 15 minutes. It's not convenient. If you're somebody who's struggling and you really need access to healthcare, it's not safe. So we need to just blow that out of the water. Convenient pathways for patients are ones that they're going to use. Improving patient access to healthcare, which is what they really want. They don't necessarily want loads of appointments. There's not a single study that has not shown that to be of huge benefit, both in the planned care and the UEC setting. So, convenience is utterly and totally important. I think from a clinician point of view, particularly when you've got a pressurized system, you will do what is convenient. And if you've got a convenient digital pathway and you can use it and you've got timestamps or what's the opposite of a timestamp? You've got location stamps where you know where a patient should be according to a digital stamp. That all of that improves tracking of patients, understanding where a patient might have got lost in the system, and it improves our access to them and their access to us. So, it is 100% the most important thing that we can do. We've evolved a system that spits out outpatient appointments, not because we decided that everyone wants to see everybody in outpatients, but because the NHS has been going much the same way for many, many years. And I suspect back in the day, it was really difficult to get hold of your clinician. Therefore, you would see your patients on a regular basis. The same with primary care, you'd see your GP on a regular basis, and it sufficed. We just don't have that capacity anymore. We can't be seeing people every 3 months or so. For example, my practice, I can't be seeing lab codies in clinic to make sure they're okay 2 weeks down the line. So therefore, how do you get around that? You create digital pathways. I can safety net that patient. I can send them a questionnaire. I can ask them to upload a picture of a wound to make sure that it looks okay, or just ask them, because a lot of this is about empowering patients. Are you happy with your wounds? If you're not, take a photo, send it back to me. So we need to find a way of improving access out of a contemporaneous contact with the patient, either telephone or face-to-face. And I don't see any convincing solution to that other than using digital pathways. And patients like it. When was the last time anyone in this room, virtual room, walked into a travel agent's? We do things online. We order stuff off Amazon. We book things online. Our patients are the same. They don't particularly want to spend 5 hours sat in my clinic waiting to see me. They've got things to do. They've got shopping. They've got to pick up their mum. See what I mean? So yes, it's not convenient. It's an absolute necessity. And those digital pathways have to bridge the gap between reducing the footfall within clinic, because that footfall in clinic is preventing us spending time with the complex patients, which I said at the start, but it's also causing delays in patients who need treatment because they can't get in because we're following up someone with essentially a normal scan in a clinic setting.
Yeah, I completely agree. I think it's such an interesting kind of idea that still permeates the health system, which is that if we're not seeing patients face to face, then by definition that's in some way unsafe, and it just isn't true, is it? There's obviously a balance, and there's a requirement to be able to monitor and track patients' symptoms to make sure that we're very reactive and able to sort of provide that safety net. But the idea that the only delivery mechanism for that is synchronously face to face with the clinician in the consulting room, I think is still an idea that sort of gets bandied about, but isn't really a requirement anymore. Fantastic, thank you both. Really, really comprehensive answers across those. So let's open up the room a little bit. We've got half an hour to kind of answer some of the questions from the audience. So audience members, if you'd like to sort of reflect on that and on what you've heard, all questions welcome. If you could start to put them in the chat, just type them into the chat and we can kind of run through them and pick them out. As they start to come in, perhaps if I just kind of get us started. So Flora, if I could come back to you, I think it'd be your role at GIRFT obviously kind of gives you I suppose a helicopter view in terms of sort of the strategic direction and NHS England input. So it'd be interesting just to hear your thoughts on the 10-year health plan and that sort of analog to digital shift from a national perspective. What do we think the role of digital pathways can be in kind of delivering on that? And you can answer that obviously from a Peds rheumatology perspective or from any other. But yeah, I think that would be an interesting sort of topic from a national viewpoint.
Yeah, I mean, I think that move from towards digital is a really key part of making the NHS sustainable into the future. So it's something that we, has to be central to all of the changes we make. It's not easy, that's the challenge. So we can all think of lots of different things we would like to do to make this work better, but we have these enormous challenges across the NHS of different systems. And it is very difficult at the moment to build digital solutions that work across all of the many different systems we work with. So that's kind of going to be a key challenge for us and for government as we work towards improvement. It's absolutely not a challenge we can't overcome, but it's definitely something we need to think really hard about. So there's something about, as clinicians, thinking of the solutions that would work and then turning yourself to kind of the slightly bigger picture at national level and thinking, well, how do I make this solution function in the context of the many different systems we work in? It's a challenge, and I know a lot of people are thinking about this at the moment, and there's lots of kind of solutions being put forward, and there is not going to be a one size fits all, because that's not what happens in the NHS, is it? So what's also going to be really important is being really clear that you understand the bigger picture of what's happening in this arena.
Thank you. And there's questions coming in, so we'll try and get through as many of these as we can. Giuseppe, could I come to you for Hope's question on challenges, I suppose at a general level, to introducing digital innovation into clinical settings?
That's a good question. Greatest challenges in using digital innovation in your clinical workspace. I think it's mostly cultural, actually. I think the biggest challenge, because there's a lot of stuff out there that you need to get the clinical buy-in first. And I think you said it, Pete, when you were talking about there's an underlying assumption that seeing someone in outpatients is somehow safer. It ain't. If they're waiting 6 months to see you, it really isn't, and they get lost because they've been waiting so long that they then DNA. So getting over the clinical bit, I think that's the key challenge. There are, and I don't know if this is just UHL specific, I don't want to slag off my own hospital, but there are certain structural issues with getting some of this stuff integrated and going through the relevant processes. But that might just be very specific, because a lot of these digital innovations, they do need to be integrated properly with whatever PAS system that you're using, because that's when they really start to hum along, because then you've got that moving patients forward along whatever pathway they're on, because you've got a timestamp that's created. For example, if you accept a patient from primary care, and then you get a series of questionnaires that come out, or when they've had their surgery, then you can get the post-op questionnaire goes out. So yeah, the biggest challenge, I do think, is clinical, and then the second challenge is the integration bit.
Yes, yeah, I'd agree. Flora, did you have anything to add there?
Yeah, I totally agree. No, I think that was a really good answer.
Great. Okay, and then a couple of interesting questions on primary care, which I do think is the area that there's huge potential if we can be launching these pathways from sort of as far left as possible, and by that I mean sort of almost, well, not almost, pre-referral, such that we can be validating
100%.
the referral sort of long before it hits secondary care. So I think that's a really fascinating topic, and it's very, to me, it remains very unsolved. But we're making headway. So can we perhaps spend a bit of time on that across both of your specialties, and then we'll kind of come back then to Philip's questions after that. Who'd like to go first on primary care input?
I mean, this is something we've been thinking about a lot recently, so I guess I can start here. So what we know in my world of paediatric rheumatology, and we know this from GIRFT, and we know this from a recent NCE pod investigation looking at children with arthritis, we know that there is wide and really troubling variation in the time it takes to get that child from first presentation to our medical professional to the paediatric rheumatology team. And there's lots of different factors contributing to this. So therefore, building a pathway that begins at the point of that first presentation to medical professionals is absolutely critical, I think, to reducing unwarranted variation, to reducing delay. So we've been thinking about that a lot in our world and how we might do this. And clearly, what we've been doing is talking to primary care teams about how we might do this, because it's really difficult, isn't it, as a clinician who works in a hospital, to understand what the kind of challenges and barriers are in primary care. Actually, it does seem to be really tricky. So it seems that primary care across the country, people look in different places for information and advice. They're not all going to the same kind of central pot. So that's our first challenge. And then the second challenge in the world of rare diseases, which is the world that I inhabit, is a primary care team might see one patient in their whole career with the kind of conditions that I look after. So if you think about the number of pathways that we're talking about introducing, this is pretty vast. So we need to be a little bit kind of cleverer than that, don't we, and think much more generically about how we support primary care to understand triggers, if you like, triggers to go in this direction or that direction with the next step. Clearly, that is work that must be led by the primary care clinicians themselves, with input as needed from us in secondary care. And I think that's very much the thinking at national level as well.
Yeah, completely agree. I think there's back to preconceptions. Sometimes I think there's a preconception that primary care teams won't want to engage in the sort of design of this, and that is absolutely not our experience across
that's not right.
the work that we're doing with the GIRFT teams. We've seen huge engagement, and I think there's a real understanding this is, well, one, for the good of patients in moving people to get the treatment they need as quickly as possible, but also just from a workload position, there's a huge operational benefit to primary care teams in not having to administer patients that are going in a big loop around secondary care to result in no treatment and end up back more disgruntled seeing GP. So there's a massive opportunity there, and I think we have the mechanisms in place to be able to really design these pathways end to end from primary care all the way through. Giuseppe, did you want to jump in on that, or should we move on to the next question?
I'll just say that I think, Flora, you hit the nail on the head, and I think primary care sometimes gets undeserved flack. So there are elements of pathways. I'll take my practice. I see patients with gallstones. It is not unreasonable for primary care to know which patients to refer and what the minimum criteria are for that. And then we need to reach out for those patients, for example, and we could do preclinic optimization. We can send out information about surgery for planning it. These are all things that we can do from our end, or even, at the point of referral. If you've been referred for a procedure, and given my surgical hat on, then why can't you start putting your steps in from now? You probably do for your holiday, and that's probably less risky than having an operation. But then there are bits where I don't think it's fair. You refer to many different pathways. So, I also deal with pancreatic cancers. A typical GP surgery will diagnose one pancreatic cancer every 1 to 2 years, or patients with chronic pancreatitis. It's unreasonable for primary care to know every single different pathway. So for those, you need more of I like my analogies, almost like an open hopper, where anything that loosely fits into non-gallstone, if you use my specialty as an example, gets treated as a single point of access with digital questionnaires, etc., to kind of make sure that we risk stratifying cohort patients to be seen by the right thing. So it needs to be that nuanced approach of what is reasonable to expect primary care to know and do, and what we should be taking the lead on, I think.
Yeah, yeah. Thank you. Great answers. Just come to Philip's questions, which maybe I can answer. So knowledge assets like questionnaires have been standardized to share across multiple EPRs and decision support tools. Yes, to the maximum extent possible. So certainly in the way that we're helping to tackle this with Isla, we're advocating for standardized assets. That can be information that is sent to the patient, and wherever possible, we'll sort of defer to the appropriate clinical body on that. So as a GIRFT example, there's lots of assets which have been produced within the GIRFT Academy and have been clinically validated, and so we'll use those as core parts of the pathway. The pathway definitions, yeah, this is I think where we've made huge progress in the last sort of 12 months. So the steps along a pathway and the sets of data that are required at every moment along that pathway, and then the analysis of that data that is needed to be able to present clinicians with clear sort of information sets so they can make a decision, is the thing that we're really excited about trying to sort of promote the standardization of. Because you see, I think every time we've worked with trusts sort of disparately, not doing this in a joined up way, every transformation program, and I don't think this is just true of Isla, I think this is true of a lot of sort of tech implementations. Every one of those programs often starts with this quite intensive kind of clinical pathway mapping phase, which is great and important, but I think that the step change is if we can sort of have a nationally published standard so that we're not independently across services around the country having to do this sort of pathway design from scratch, and we can instead take a standard and then, where appropriate, modify it for sort of local deployments, but as far as possible adhere to the national standard. So that's what we're trying to support with at the moment. Great. There's lots of questions coming in. Thank you, audience, for being so engaged. I'm not sure we're going to get through them all. Did you want to, Flora, just quickly touch on the inflammatory arthritis pathway?
I can do. You've pretty much just answered the question beautifully for me. Thank you very much, Pete. So what we're doing is we're trying to build a standardized pathway centrally that will work for everybody. And then what we're doing is supporting colleagues around the country to kind of pilot using the pathway digitally, locally, using the systems that they have access to. We're working obviously very closely with the adult team as we do this, and learning will be shared across, of course. Yeah, so it's as simple as that, really. It's kind of supporting people to use what they have available to them at local level at the moment.
Great, thank you. Just coming down a little bit in the questions. Interesting question from Louise there. So regarding digital open door in chronic care, has research shown whether increased clinical visibility leads to better long-term health outcomes, or are we seeing a paradox where the sheer volume of data makes it harder for parents and providers to identify urgent clinical needs? Interesting question. I can have a crack at that, and then please, Giuseppe, Flora, jump in. I think that there is a sort of meaningful challenge on how we leverage data, because access to data often is no longer the challenge. There's a huge amount of information and increasingly interoperability challenges across the NHS. So this is certainly not a solved problem, but perhaps improving. So it's becoming easier with standards to be able to go and pull information from EPRs and from other sort of master record systems. So I think the challenge becomes how we're then able to leverage the volume of that data that you mentioned, and turn that into the right information presented in the right way at the right moment to the right clinician. And that's where the real sort of design and art of this comes into it, I think, because it certainly could be overwhelming if we're not structuring the abundance of data in the right way. Hopefully that answers the question a bit. Flora, Giuseppe, thoughts on data overload?
That's a difficult one. I don't have I don't know. Data overload, don't know.
I don't know either. I do know that as we build these pathways, one of the benefits that we're seeing from them in a world that's very multidisciplinary is that we can use the pathways to get patients to the right care provider at the right point in time. So that might be a doctor, it might be a nurse, it might be a physio. It also might be our charity colleagues. So that, I think, is a big advantage of access to all of this different data. It helps patients to perhaps understand that, you know, care isn't, as was traditional 50 years ago, a doctor-led business anymore.
I'm just going to jump out of audience questions quickly, because I think there's one interesting question I'd like to cover with you, Giuseppe, and I don't want to flatter you too much on the call because it may be embarrassing for you, but I think what we've seen working with you and kind of the clinical leadership across UHL has certainly been very, very important to driving interest, engagement, and uptake of sort of this approach. So I thought it'd be interesting just to give you a couple of minutes to sort of think about any advice that you would give to other medical directors for kind of who perhaps are a little bit hesitant about this, or have tried to deliver sort of digital transformation and found it to be difficult, which it is. Have you got any thoughts there that you'd like to just cover quickly?
Yeah, I never get embarrassed by praise, so don't worry, don't ever worry about that, Pete. I think you've got to believe in it, as in it's got to have met a need. Usually in your own specialty, I find that quite useful. It's part of the reason why I've not really given up a lot of my clinical stuff. And I think Flora's probably the same. It's unless you're kind of still plugging away and doing the front end bits, you kind of lose sight of the value something can bring. So, you know, A, you've got to believe that it offers value. B, it really helps if you've done it in your area, which you know, because then you speak with a lot of credibility because you say, look, I've tried this. And there's always nuances whenever you try and put any kind of digital development out there. There'll be something that doesn't quite work or something that no one's ever thought about, you know, but having been there and experienced it, you can grade it, if that makes sense, as into how much of an issue it could potentially be. And then in terms of then engaging, I don't know. I think once I've got those other two bits nailed in my head, the rest of it's fairly easy because you're speaking from a commonality. You can basically say, this is how it's helped me in this particular pathway. You know, you've got a similar pathway. You know, what do you think? Is it something that could help you? So, yeah, it's not a polished answer, I'm afraid. Sorry about that. It's winging it.
I think that's the truth of an awful lot of the improvements that actually make a difference in the NHS, though. There is a degree of just going for it, winging it, learning, having a kind of open and honest feedback culture with everyone that you're doing it with. That's often what we find also helps. I'm going to be killed by our marketing department for saying we wing it. To clarify, we don't wing it, but we certainly take on ambitious projects and find that the way that they get delivered is through having a very open learning culture as we go. Flora, anything to add there on kind of taking the leap on digital leadership?
I think the only other thing that's really important is supporting and encouraging colleagues to look outside of their own little silo. That's a real problem for us in the NHS, isn't it? And there's so much amazing stuff goes on across one organisation that you often know very little about. So there's something about encouraging people to look and ask questions and listen. That's not always easy, is it, when you're busy and you're kind of snowed under?
Oh yeah, that's actually really important. Because, for example, let's say I was challenging Flora about paediatric rheumatology. I'm not a paediatric rheumatologist. She could tell me anything, and I'd have to buy it. But one of the good things about things like GIRFT and sharing data is that I can go, actually, do you know what? across the road or in a similar sized hospital, they have tried that and they found that it worked. So that kind of sharing is really useful. I've leaned into that very heavily in the past.
Great, thank you both. I'll interesting question or important question, I think, on how this interfaces with EPRs, which I think is worth covering from Thomas there. So I'll have a go, and then it'd be great to hear from you both on this as well. So the question is the digital implementation of pathways EPR workflow. And so then clarification on what we really mean when we say digital pathways and to what extent that is sort of just the engagement with patient component. And then the last part of the question is kind of highlighting the importance of doing this in a way which is sort of platform technology agnostic, so that these standardized pathways can genuinely be adopted across the NHS. So yeah, very, very important question. Absolutely yes is the answer to that. So and just to, I suppose, outline roles a bit. So GIRFT's taking a real leadership role in terms of designing and building these digital pathways with clinical leads across the country and peers across the country. Those are going to be published and available open source so that they can be adopted really onto kind of any technology stack. There's a very varied level of sophistication and maturity across the sort of EPR implementations across the country. So there will be, I think, examples where much of the digital pathway can be deployed in a pretty sophisticated way on EPR technology and not using too much else. And then there's other parts of the country where we're in truth just miles away from that. And so speaking for Isla, the way that we've approached this is that we've built a layer which is sort of agnostic of EPR and able to manage many of what we call the nodes along the pathway. So that might be triggering a request to a patient to send in a short video or an image or a questionnaire. It might be a request to pull a blood result from one of the pathology systems that we're connected into. It might be that we need to query something from one of the primary care records in order to inform the data set and present clinicians with what they need to make a decision. And then underpinning that is the kind of automation capability. So this is actually where Giuseppe started. So the real value and the real magic of this, if we can get to that point, is that all of the kind of administrative steps that currently take up time, such as, you know, this is the output we want, we need to book an appointment here, or we need to order this test, or we need to, you know, fast track a patient onto a different part of the pathway. Very often that is sort of fully automatable, and so the Isla technology helps us helps us to help clinical teams to do that in a very sophisticated way. And then we treat the EPR as we should, as the kind of master patient record. So we write back wherever they're technically capable of ingesting that through FHIR and H7 or custom APIs. We write back that data into the EPR. That was a little bit of a technical answer. Giuseppe, Flora, thoughts on kind of the EPR interface into these pathways?
It is really important, which I sort of mentioned. And like I said, I don't know whether the issues we've had, whether that's peculiar to where I'm working or whether it's across the board. I think someone put in the comments about almost having like a national agreed, I can't forget the exact wording, CSO light, which I think is a fantastic idea, to be honest with you, because if you're adopting one particular piece of technology across more than one trust, you know, it seems perfectly reasonable and quite pragmatic to adopt that kind of view, to go, look, you only need to have one check, and unless you've got a particular trust that has a unique risk which is not present elsewhere, then that check will suffice. I think that would really help upscale some of the implementation of this technology. I don't know if it's feasible or not, because I'm not very IT driven, but yeah, it sounds like a good idea.
It's really difficult, isn't it? So my specialty is small, so we work very collaboratively, and we frequently, you know, share discussions across many centres across the country. So we're very accustomed to the challenges of sharing across different EPRs, and they do work very differently to each other, and they are very differently mature to one another. But we're at a really early phase, aren't we, in the world of building digital pathways? So I just feel we've got to work through some of these challenges with the longer picture, the bigger picture in mind. So what's the aim? The aim is that we get the right care to the right patient at the right time. I think it's going to take 3 steps forward and 2 steps back for a while till we get it right.
Yeah, and then I think related to that question, interesting question from Anya about how the impact of budgeting across primary and tertiary care can impact the adoption of this. I think that is a really great area, because alongside redesigning clinical pathways and moving into kind of automating these as far as possible, where there will be constraints where this doesn't actually line up with, you know, the revenue model for secondary care or primary care or any other part of the system. So I don't know to what extent you're sort of able to comment on this from a clinical perspective, but I do think there needs to be a real joined up NHS England-led approach to rethinking the sort of commercial incentives around the way that we deliver care, because very often there are incentives which are misaligned with the way that care could be delivered most efficiently. So yeah, obviously a huge topic and a huge challenge, and these things can't be changed overnight, but I think we need to be rethinking the commissioning model to support a different operating model. Anyone want to wade in on that one?
Because the second part of that question was around adoption digital pathways prevention. I'm thinking now purely with a surgical hat. I think there is evidence, though, that patients are more likely to adopt lifestyle changes in response to a request from a hospital specialist, and particularly if they're having a procedure or intervention. So that right there, which is, I'm choosing that one deliberately because that's actually quite an easy one to do in some ways. That right there, you think of all the high volume, low complexity pathways we have in a typical hospital, is something which is relatively low cost. I mean, I mentioned that thing of, start getting your steps in, or giving them it doesn't have to be if you're not having a massive operation, you're just having daycare surgery, you don't need the prehab team, you just need perhaps access to a simple digital tool so you can count your steps. So in a very, very small way, you could almost start that immediately, couldn't you? And that doesn't require any transfer of budget. I think there is an impact that will eventually be had. So I think there are still ways of doing it, but I agree with what you're saying, Peter, that in a large scale perspective, it probably does need more formalized budgeting.
Yeah, agree. Okay, we probably don't have too much time for questions, because I think it'd be great just to sort of do closing thoughts. Thank you to everyone in the audience, because there's a really great discussion going on here in the chat. We will be sharing the video around. Whether the chat transcript will be included, we'll pick that up. I'm sure we can find a way to conquer that particular hurdle. And also feel free to reach out to anyone on the group. And to both Flora and Giuseppe we work with, they're incredibly passionate about driving change forward, so I'm sure they won't mind anyone getting in touch. And then just to kind of wrap up, a huge thank you from me, because you're both wonderful colleagues to work with in driving forward this sort of very ambitious program. I think it'd be interesting just to sort of give the floor back to you to close off with sort of one key takeaway or piece of advice or thought that you'd like to share with the room in terms of how we can sort of leverage this or any other approach to really drive forward the health system. Flora, shall I come to you first on that?
Yes.
Yeah.
Yep. Thank you for having me. It's been a great session. I think my final comment would just be change is necessary and inevitable in the NHS, but change shouldn't be siloed. So what we should be doing as we move forward over the next few years is looking outside of our own small worlds and learning from colleagues. that's the way to do this as best as we possibly can.
Thank you, Giuseppe. You've had 30 seconds to think.
It's just long enough. I think my 3 points for all of this is we need to improve access in both ways, us to them, patients to us. We need to standardise and timestamp low complex care so we can spend time on the more complex patients. And the final one is none of this should replace clinical judgment. This is all about reducing the noise, which does actually cloud clinical judgment, because at the front end, if you're seeing a load of low value patients in clinic, you're probably working harder than ever, you know? And yeah.
Yeah, that's I'm staggered that AI hasn't come up in this conversation so far, but I do think that's a great place to to close off, because yes, I couldn't agree more there. I think there's a real danger of running before we can walk here, and we need to be leveraging the very, very exciting advances in technology to help us kind of meaningfully quantify the problem and sort of drive through process improvement. And in the future, there's you know, opportunities that will create, but we should not be taking leaps to start thinking about replacing clinical judgment in this. It's just not the right way to tackle the problem. So I think that's a very, very good place to close. Thank you very much, everyone, for joining us. I'm sure there's going to be many conversations that come out from this. So please do get in touch if you'd like to learn more and talk about it. I can see there's already an invitation to run a guest lecture there on an MSc. So that's an exciting opportunity. Thanks, everyone. We'll leave it there.